Good morning. My name is Emil Tucson, and joining me are Holly Marks, Kelsey Allen, and Dion Tyler. Thank you so much for this opportunity. Today we'd like to present to you Cardinal Connection, our bundle for reducing the opioid epidemic in West Virginia. We'll go over our agenda. First, we'll define the opioid epidemic both on a state level in West Virginia and on a national level. We'll take you through our purpose and aim, our root cause analysis, and the framework and inspiration for our bundle, which we're again calling Cardinal Connection. We'll take you through the financial implications of that and discuss some future opportunities. So the opioid epidemic is just that. It's an epidemic. As you can see by the most recent data in 2015 from the CDC Wonder, overdose deaths hit every single state in our nation. As you can see, West Virginia was leading the nation at 41.5 deaths per 100,000 in 2015. Compared to the U.S. rate in the bottom right corner of 16.3, West Virginia has 2 to 3 times higher of a rate than the nation. In addition to having a higher rate, as you can see, between 2001 and 2015, West Virginia was also having a higher rate of rise annually, meaning that this problem was compounding upon itself in West Virginia more than in the rest of the nation. In particular, the southwestern counties of West Virginia seem to be the most densely affected. This happens to be relevant for our case because, as you are aware, Densford County, West Virginia, happens to lie in the southwestern portion of the state as well, meaning that those affected, particularly George and Beth and others like them, are being surrounded by other communities that are similarly affected. In Densford County, you can see other barriers they have. They have a higher rate of unemployment, disability, and poverty when it comes to the national level and compared to West Virginia. And in addition, they have a higher rate of uninsured people compared to West Virginia as well, all four giving them more barriers to health care.
So while you're familiar with the cases of Bethany and George of Densford County, this slide provides an overview of some of the key factors that contributed to their incidence as well. So commonalities between the two include stress, acute and chronic pain, mental health illness, and a lack of protective measures in place which help contribute to their preventable overdoses. We also have a more detailed timeline in our appendix as well for your reference. So our purpose, why are we here? We would like to propose new initiatives and fortify pre-existing initiatives in order to decrease the opioid overdose death rate in Densford County through a multidisciplinary and community-driven approach. So through these initiatives, we will reduce the opioid overdose death rate in Densford County by 20% in the first 2 years.
So we took both Bethany and George's sentinel events and we conducted a thorough root cause analysis. We started by conducting a fishbone diagram. We identified the effect as Densford County's opioid-related addiction, overdose, and death. We then identified 5 major categories, those being patient, sociocultural, system, hospital and emergency department, and provider factors. From there, we took the root cause analysis one step further and we performed a key driver diagram. We identified the primary drivers that were directly impacting our aim or goal, which was to decrease the opioid overdose and death rates in Densford County. We then broke those primary drivers up into secondary drivers, which revealed unique opportunities for potential solutions, as you can see here. The ones that you see highlighted in teals are the interventions that we have chosen to present to you today. We determined this by plotting all of our interventions on an effort yield matrix to prioritize which interventions we would want to implement first. So today we would like to recommend to you all the following recommendations. The first being we're going to improve Densford County's technology infrastructure, implement a community-based mental health support program, and implement practitioner and emergency department toolkits. We intend on impacting the following 4 areas with our recommendations, those being Densford County's technology infrastructure, the community, which would involve the patient, like Bethany and George, practitioner services, which would include pharmacists and primary care providers, like Lester Buford and Dr. Jones, and then emergency services, like St. Mary's Emergency Department.
So without further ado, we present to you Cardinal Connection, again, our bundle for reducing the opioid overdose death rate in Densford County. We called it Cardinal Connection for a few reasons. The first is the word cardinal, when used as an adjective, means of the utmost importance or significance. And we found through our research that the opioid epidemic affecting our country is of utmost significance, and we find that our interventions are important in that regard. We call it connection because we're connecting through our interventions, as you'll see, people to themselves, people to their resources, and people to each other, which we find very fitting and as a theme in all of our interventions. In addition, the state bird of West Virginia happens to be the northern cardinal, which we find to be particularly fitting for this intervention. We'll talk about the framework and inspiration for our intervention, which is Project Lazarus, which is a nonprofit health organization that was created in 2007 to combat the opioid epidemic in Wilkes County, North Carolina. At the time, North Carolina was the #3 state in the entire nation for opioid overdose and death, and Wilkes County was the unfortunate leader in the state. Project Lazarus has two driving foundational principles. The first is that overdose deaths are preventable. This is important because it means that all the effort required to fight this epidemic will be fruitful and worth all of the effort that is put in. The second is that communities are ultimately responsible for their own health outcomes. This is really important because in the past, whenever there's been an epidemic or social issue that affects a particular region, organizations or legislators or things that are similar come in and say, we will fix the problem for you through X, Y, and Z. What made Project Lazarus different is that they equipped the community with tools so that the community could now have ownership of the problem and continue to fix it for themselves moving forward, an idea that we particularly liked. So our recommendation is to adopt and tailor Project Lazarus for a few reasons. The first is that Densford County is extremely similar to Wilkes County in regard to the opioid burden, geography, culture, and employment. The second is that Project Lazarus is simply data-driven. Between 2009 and 2010 in Wilkes County, there was a 38% reduction in overdose mortality. During the same time in North Carolina and in the country as a whole, there was an increase in those rates. We don't find that to be a coincidence. There was also a 72% reduction in the number of prescriptions from providers implicated in the overdoses between 2008 and 2010. This indicated that there was such an immense impact on providers and pharmacists and healthcare professionals alike.
Okay, so our first intervention is to improve the technology infrastructure in Densford County. So in order to achieve our greatest potential with the Project Lazarus framework we have, we would like to start by improving the internet reliability within Densford County, specifically for the providers. So based on the FCC's 2018 broadband deployment report, they highlighted satellite issues as being one of the main barriers to closing the digital divide, specifically between the urban and rural communities. And so the Viasat business plan allows for a 15 megabits per second download and 4 megabits per second upload speed. And so we decided this would be suitable for a clinical practice, such as Dr. Jones's. And it later allows for an upgrade to Viasat 2, which I will touch on in just a minute. So the second piece is improving the broadband. So we would like to pair Densford County with the Cool and Connected Assistance Program. And so this is mainly focusing on counties in the Appalachia region, specifically those adversely affected by the coal mining downfall. And so what this program does is it essentially utilizes the broadband already in existence or what resources the county may have, and it capitalizes on those. So it improves what they have in areas such as education, healthcare, and government. And it really helps to revitalize the community in an economical sense as well. And then also within the broadband, as I spoke on, we would like to upgrade the providers to Viasat 2, which is being released later in 2018 for the commercial side of healthcare. And so then with those two pieces in place, we would like to then try and implement an electronic health record with Dr. Jones. So we know this is a seemingly daunting task, but we really looked into it and based on the information we had, tried to tailor our selection to Dr. Jones's clinic. And so we landed upon Practice Fusion. So this is a low-cost, very user-friendly, and cloud-based electronic health record. So it would not require any additional investments as far as hardware. It would use what Dr. Jones already has in place. It is also certified, which was very helpful for later on achieving meaningful use stages. And it is also has customizable templates. So this is particularly helpful in the mental and behavioral health sector of healthcare. And then lastly, with the electronic health record in place, Dr. Jones will be able to utilize the Health Information Exchange of West Virginia. So while Practice Fusion may not be interoperable with different clinics or hospitals in the state, it does provide that ability for him to add his data and also extrapolate other data to see the common causes around the state. And then lastly, it will also allow both providers to utilize the CSMP to improve their prescription practices. So overall, the technology infrastructure, we're going to install, partner, connect, and utilize both things already in place and also add to that.
Our second intervention is to implement a community-based mental health support program. Along with the other barriers that West Virginia has faced as we've discussed, you can see between 2011 and 2015, West Virginia had a higher percent of adults aged 18 and older with serious mental health illness as compared to the rest of the United States. Again, just creating another barrier to care. In particular, as Dion mentioned earlier, mental health played a large role in Bethany and George's cases. Commonalities included unresolved trauma and depression, death of a significant other, untreated physical and emotional pain, and relative isolation, all of which led to a predisposition to use substances. For this reason, we'd like to implement what we're calling neighborhood socials, a community-based mental health intervention. After reviewing the meta-analyses of specific community-based mental health interventions specifically for depression, we found that a few in particular significantly reduced depression scores on the Beck Depression Inventory 2. One such intervention included participants were offered a telephone number after they had been screened as either having mental health illness or being at risk for developing mental health illness. With that telephone number, they could call toll-free and were connected to a professional and/or paraprofessional who helped them with communication-based skills training. The training included discussing what does it mean to have mental illness? What kind of barriers do you face? After they got that training, they were then paired with another participant who received similar training. The pair was then able to talk to each other over the phone as well and discuss what types of barriers do they have in common, what things are different, what coping strategies do they use. At that time, multiple groups of pairs were brought together in a community setting such that they could increase the diversity of the discussion and see what kind of coping mechanisms each person used. So what we'd like to do is first bring the community members together in a town hall meeting. Identify the challenges by saying, what do you face? What are the issues we can help with? At that time, we'd like to get commitment from the stakeholders and identify what people in the community have responsibility with mental health and what can we do about it. At that time, we'd like to also obtain the necessary funding. Next, we'd like to build the program by training Marshall School of Medicine providers and providers in training to do this community-based communication skills training. Marshall School of Medicine happens to be the closest university school of medicine to Densford County, which is why we'd like to have Marshall to have some stake and claim in the pie as well. At that time, we'd choose community leaders and identify specific meeting locations for these community events. Some preliminary ideas we've included are the infrastructures that already exist, including the Chiron Integrated Health Center, Grace Women's Health Clinic, the local health departments, churches, fire departments, and other community organizations. At this time, we'd also like to integrate with the Governor's Advisory Council on Substance Abuse, or GACSA's Substance Abuse Coalition that they've already created in their most recent report. They've identified certain regions around the state as well that could help in this claim. Next, we'd like to implement the socials by increasing the awareness of both providers and of participants and citizens in Densford County, making them aware that this is a service that they now have. We then start by doing teleconferences, giving them the training, and then pairing them together and doing regular events in the community. At that time, when we give them the number, we'd also like to give them GACSA's hotline number that they've already created, which is for people who have acute, serious mental health illness and need help now. We'd also offer that and not reinvent the wheel. Finally, we'd like to sustain this effort by continually reassessing, asking the community what can we help with, what are we not doing well enough, and continue to support the community leaders who are looking to take responsibility for the rest of the group. Imagine if you take George and Bethany's cases, how they'd be different if something like this existed. They'd be able to, again, connect to themselves, connect to each other, and connect to such a resource like this. Their stories would be completely different.
So for our final bundle of interventions, using Project Lazarus' toolkits as a framework, Cardinal Connection will assemble and distribute practitioner and emergency department toolkits. So there are common themes shared between the two toolkits, including utilization of West Virginia's prescription drug monitoring program, Narcan utilization and education for the community and for providers alike, referral to outpatient community resources such as the neighborhood socials that Emil just detailed, and then the use of opioid screening risk tools and proper prescribing habits as well. So the emergency department toolkit is, the emergency department is a prime setting to provide overdose education and distribution of naloxone for individuals, and is an intervention that is shown to reduce opioid overdose death rates in similar communities which are also plagued by high overdose rates. So for our first step, we will utilize evidence-based practice for treatment of acute and chronic pain. So this will help train those providers to appropriately manage those pain conditions. Next, we'll identify patients at high risk for opioid overdose using our opioid screening risk tools and look for potential drug interactions and comorbidities as well. Next, we'll educate bystanders on the risks of opioid use, and so this will help train those bystanders on the risks of or the signs of an overdose. And then next, we'll distribute take-home Narcan kits and educational materials in order to further arm those patients and those bystanders. Also, an order set can be built into the EHR in order to increase provider ease of access, and we have an example of this in our appendix as well. The practitioner toolkit will mostly be implemented in primary care settings, but will also involve pharmacists as well. And so we'll inform practitioners on appropriate chronic pain management using Project Echo. So Project Echo is a free resource that links rural healthcare professionals through technology with specialists to provide updates on chronic pain management and research. Next, we'll educate practitioners on appropriate Narcan utilization and overdose prevention. So as the epidemic has grown, healthcare professionals have expressed discomfort and uncomfort with using Narcan and distributing it. So this will help address some of the stigma and the misconceptions with its use. Next, we'll screen patients for underlying substance abuse and mental health illness. So as we've talked about before, Bethany and George have many opportunities to be screened for mental health, which were missed, and so this will help address that problem as well. And then lastly, we'll treat opioid-dependent individuals through office-based medication assistant treatment, also pairing with Project Echo and their education on this. So this will just inform providers on alternatives using MAT since there's a saturation of methadone clinics in Densford County.
We constructed a thorough stakeholder analysis for Cardinal Connections, identifying specific stakeholders and their degree of impact, influence, importance, how they can contribute to our project, and then how we can engage them. We wanted to make sure that the recommendations that we are presenting to you today are in alignment with the National Academy of Medicine's 6 domains of healthcare quality. And as you can see, we are in alignment.
So our funding for our intervention, so how we plan to subsidize these. So I wanted to point out 2 important areas of our research. We found a lot of both state and federal funding opportunities available already through grants and programs. And so we would try to utilize the FCC's Rural Healthcare Community Program, which has 3 different programs and funds available, specifically focusing on closing that digital divide I touched on earlier. And also, I'd like to highlight the CDC Prevention for States funding. So this is specifically focusing on those people trying to combat the opioid epidemic. So a little bit into our expenses and our break-even analysis. So we projected the first 2 years of our startup costs, and so it totals out to be around $92,000. And then we took it further with the cost per capita. So based on the 25,000 residents of Densford County, it comes out to be $3.71 per person, which, as you can see, is a pretty small investment for the proposed results that we will obtain. And then going to our break-even analysis, we have the average national cost for the opioid-related poisoning events in hospitals. And so this is around $37,274 per episode. So this could be an emergency department treat and release, inpatient hospitalization, and mortality rate. And so in order to break even on our investment, we would need to prevent 2.48 of these hospitalizations and events on average. And so we just thought that was a pretty obtainable area.
We plotted all of our recommendations on a timeline. So from today to the next 3 months, we're going to start improving Densford County's technology infrastructure, getting stakeholder commitment and funding. We're going to work with the local health department to create and identify a project manager that's going to oversee Cardinal Connections. We will also identify key community champions to get their buy-in, and then they will go out into their respectable sectors and get buy-in from their peers. Also advertising for this town hall meeting that Emil talked about. Around the same time, from 3 months to 6 months, we're going to start assembling these toolkits, getting neighborhood socials up and running, and then disseminating the toolkits. This is all done through a cycle, as you can see here.
So thank you so much for listening to our bundle. Again, we're calling it Cardinal Connection, which we plan to reduce the opioid epidemic in Densford County and ideally extrapolate to West Virginia and then to the nation as a whole in a perfect world. As you can see, these are a few of our future recommendations and other considerations we took while obtaining our research, and we'd be happy to answer any of the questions that you may have. Thank you so much for your time.
Project Echo. It's my understanding of the Project Echo that you've got to establish a hub, your own hub. Is there an existing addiction hub, opioid hub for Project Echo right now, or are you going to have to establish one?
Answer that. Is it okay with you guys? That's a really good question. There actually is, and that's we're not going to reinvent the wheel. We're going to use what's already in place. We're just going to help connect that to our residents in Densford County. So the hub is actually in West Virginia at the West Virginia Institute of Technology at that university there. And they've got a series of different projects going on, which is the Project Echo chronic pain and then Project Echo office-based medication-assisted treatment. So, you know, using Holly's intervention that she talked about, we're going to improve the internet and broadband connection, which will also help our providers be able to connect to them and utilize that. But good question.
Thanks for your presentation. I have a few questions. I'll and stop me if you have others. The Project Lazarus. I'm really familiar with Project Lazarus. Fred Brayson, who implemented that in Wilkes County. I'm wondering, did Project Lazarus have to do the increase in technology infrastructure to accomplish their goals? And if not, why did you choose to focus on that when you're modeled so closely after Project Lazarus?
Yeah, so actually we called Project Lazarus and spoke pretty extensively with a lot of the community members. Unfortunately, we were unable to speak to the founder. He was busy. But in Project Lazarus, they did not do any big major technological infrastructure changes. The main reason that we found that to be so critical here was because in the community in Densford County, they have a basic, simple satellite internet provider, which, as you could see in the case, was not reliable. So the orthopedist and some of the other specialists, along with Lester Buford and Dr. Jones, they were unable to effectively communicate and trust that their provider internet service was going to work. We simply live in an age now where it's important that we have internet connection, and as Kelsey mentioned earlier, being able to connect to some of the further away infrastructure, especially because there's only one major road in between a lot of the cities, is super vital and important. So although Project Lazarus did not have that as one of their main components in their intervention in Wilkes County, we felt it was important, and that's why we tailored it to Densford County that way.
So talking about Jones, Dr. Jones and Lester Buford, I think I heard you say you want to inform them about, for lack of better words, evidence-based prescribing dispensing practices, correct? And then screening for high risk, things of that sort. How do you propose to get buy-in for those things?
So I can answer it. It's okay. Mm-hmm. So we feel like in screening these patients and identifying those mental health or illnesses that could occur in these patients, we feel like we will prevent readmissions, and it'll kind of make their practice easier and take some of the patient load off if these patients aren't coming back multiple times for pain. And so one of the CDC recommendations for the guidelines is that you have to kind of treat those comorbidities and those mental health illnesses first, as those could exacerbate pain and prevent the resolution of pain. And so we feel like being able to convince them and explain this issue to them, they will be able to better take care of their patients, and then we're reducing healthcare costs as well for them so that they're not coming back for the same pain because we're not treating the root cause of their mental health illness. So we feel like being able to explain that to them and tell them that we're going to reduce their healthcare costs and overall take care of their patients better will be how we'll buy them in as well. Also, we can also bill for the educational services as well, which will provide sustainability for our project as well.
Do you have specific screening tools that you want to see implemented in the primary care clinic to pick up on both the mental health side and the addiction?
We would like to use the Cage Aid and then also Dyer as well in order to kind of look for those mental health illness problems and screen for those and assess them as needed.
So to follow up on the question before, so your consultants, you're coming here with your recommendations. How do you propose to get, in a kind of asking the same question, but in a broader way, community buy into what you're doing here? I mean, how are you going to transition with the slick slides? It all looks great to actually the community saying, you know, this really makes sense to us to really buy in. How are you going to develop champions? How are you going to move this forward in a community? Our community here in West Virginia, we have a very distinct culture. How are you going to do that?
I can take it. So what we found during our research is that the Appalachian people, particularly in West Virginia, have a baseline distrust of healthcare providers. And we found that to be relatively important because that's why we wanted to do a community-based approach where they have ownership over their problems. So as we discussed briefly, we were going to start with a community town hall, basically saying anybody who would like to come and discuss more about what we can do to make Densford County prosper a little bit better. Are you having financial downturn? What are the barriers to that? Oftentimes finances especially get people's attention. Say, what kind of barriers do you face in your mental health? What kinds of programs can we help you create to improve that? What are the physical ailments that you have that are not being treated and are going unrecognized? What kinds of social supports and community support programs do you already have, and what else do you see could fit? So just by bringing a community town hall, people see, hey, there's my neighbor. Hey, there's someone like me. Although there will be healthcare providers and other professionals there, the majority of the town hall in our vision is to be made up by community members as a result of the Appalachian people having a specific distrust in healthcare members. From that point on, similar to Project Lazarus, it's important to identify who are the community champions, which is the term is used in Project Lazarus. These are the people who are having specific difficulties, but also recognize that they'd like to take a big bite out of the problem and are specifically motivated to help with the solutions. At that point, as Kelsey mentioned, those community champions in particular would get invited to a roundtable, more intimate discussion with the project manager and the other providers to say, okay, now you've decided you want to lead. Here are the tools we can help with. What are your community members saying? What are your neighbors saying? What are the things that we're continuing to have difficulty with? What's the data? How can we reevaluate that? So to answer your question, most of it is getting a community-driven approach just by bringing people together and allowing us as consultants and you as the government and larger body to remain on the periphery and say we will support you from the outside as long as you can drive it from the middle.
I'd also like to add to, Emil, too, as we had mentioned, because we thought about the same thing. We specifically would like to work with the local health department. I'm not sure if Densford County has one, but whoever is doing a community health assessment. So they're already aware of the problems of Densford County and the unique struggles. So that project manager would be able to identify those key community champions by kind of immersing themselves in Densford County and asking people who do they respect? And then also utilizing the local health department. They have access to the data that is driven straight out of Densford County. So just making the community aware of their county and specific numbers from their county will also help kind of get their buy-in.
At the very beginning of the recommendations, you set a goal of a 20% reduction, I think, over 2 years in opioid deaths. And I was struck by the fact that Project Lazarus had a much better outcome over 2 years. So why did you set the goal at 20% versus the Project Lazarus goal, for example?
So I think we faced something unique that we had to deal with the technology barrier, and that is going to take some time to implement. So based on the information, I couldn't really give kind of a rework or do any kind of time analyses for Dr. Jones and what his clinic would look like with implementing that EHR. And so we wanted to allot for time to make sure that Practice Fusion would be something that would be obtainable for him to implement into his practice. Wanted to make sure that that was comfortable first. And so also the establishing of broadband and heightening those resources takes a little bit of time as well. And so we just wanted to make sure we accounted for that piece of it, that Project Lazarus didn't have to deal with as much. And also we have about approximately 1/3 of the population that Wilkes County did. And we also did not, we have a few less workers based on the lower population. There were just a few things we wanted to account for, and also it is a different region. They're very similar, but we can't say for certain. So we wanted to make sure that we had an obtainable goal that we could go back and check in a few years.
And I'll just add briefly to that. One of the difficulties we find when large organizations are making goals for this is that they make the goal too lofty, and then once they're unable to attain it, they feel like they've failed. Instead, let's make a goal that we feel like we can actually earn and is not too lofty, such that when we hit it, which we're very confident about doing in 2 years, then we can reevaluate and reassess and make a new higher goal.
I appreciated you involving Marshall School of Medicine in this, and I'm curious why you chose to stick with just the School of Medicine at Marshall and not some of the other health professions colleges at Marshall.
So I think we chose Marshall. Densford County is not real, but based off of our location, Marshall University is the closest proximity. So we could get those, providers and residents and nursing students, all those interprofessional teams. Thank you.
Thank
Thank you.
you.
Thank you.